Good morning. Yesterday there was a very good discussion on chimeric flaps by Dr. Dushan Jaiswal. So usually we take chimeric double paddle fibula flap on the septocutaneous perforators if we have to. But very often we don't find two septocutaneous perforator and we find just one septocutaneous perforator. Even in those situations we can get two skin paddles, and this video will just demonstrate that. This video will demonstrate the harvest of a chimeric double paddle osteocutaneous fibula flap. Two skin paddles taken in a chimeric fashion offer more flexibility when multiple anatomical sites need reconstruction along with the bone. There are three options for designing the second skin paddle. The easiest option is using a second septocutaneous perforator. However, if this is not possible, we can use the lateral supramalleolar perforator or a musculocutaneous perforator through the soleus muscle for a second skin island. This photograph shows the marking of the fibula osteocutaneous flap with the supramalleolar perforator marked in the distal leg. The entire flap harvest is done under tourniquet control. We start by making the anterior incision of the skin flap, and the incision is deepened through the fat. The flap is then raised in a suprafascial plane till the peroneus longus tendon is identified deep to the fascia. This suprafascial plane helps in preserving the superficial peroneal nerve and also helps in better skin graft take. Once the posterior border of the peroneus longus tendon has been identified, then the deep fascia can be incised posterior to it along the entire length of the flap harvest. This brings the muscles of the lateral compartment of the leg into our view. The muscles of the lateral compartment are separated from the posterolateral intermuscular septum with blunt dissection using a finger. This exposes the septum, and the septocutaneous perforators are then identified and marked on the skin surface at this point. At this point, we start harvesting the lateral supramalleolar component of our double paddle fibula flap. The lateral supramalleolar component of the flap is also harvested in a suprafascial plane. We start by identifying the perforator, which we had already marked preoperatively using a handheld Doppler. The perforator can be seen at this point just deep to the scissor. Note that the perforator of the supramalleolar flap is anterior to the peroneus longus tendon, unlike the regular septocutaneous perforators of the fibula flap which are posterior to it. We carefully incise the deep fascia around the perforator without injuring it. The lateral supramalleolar perforator travels between the lateral and the anterior compartment muscles of the leg. Once the perforator has been freed from the deep fascia foramen, the rest of the flap can then be islanded. This helps in easier dissection of the perforator. As the perforator is relatively small in size, care must be taken to avoid excessive traction on the flap to prevent injury to the perforator. The perforator dissection is relatively straightforward. Small branches from the perforator, which are going to the nearby muscles of either the anterior or the lateral compartment, can either be clipped or coagulated with a bipolar cautery. This perforator arises from the distal end of the peroneal vessels, and so it can be traced all the way down to the interosseous membrane. As we go proximally, you can see that the perforator is increasing in size and the dissection becomes easier. Once we have reached the interosseous membrane, we again divert our attention to the harvest of the fibula flap. So we start by raising the lateral compartment muscles of the fibula bone. We leave a small cuff of around 2 mm of muscles over the bone. This preserves the periosteal supply of the bone. This is done along the entire length of the fibula bone. Larger vessels need to be clipped in order to avoid postoperative bleeding. In the upper part of the harvest, the superficial peroneal nerve comes into picture and must be preserved. At this point, the dissection is closer to the fibula bone. Once the lateral compartment muscles have been elevated, we incise the anterolateral septum and then we free the anterior compartment muscles off of the fibula bone. In the lower part, we must take care not to injure our lateral supramalleolar perforator, which we have already dissected previously. Once the anterior compartment muscles have been freed, we incise the interosseous membrane, starting at the level of the supramalleolar perforator, which is seen just distal to the scissors at this point. Care must be taken to not injure the peroneal vessels, which lie very close to the membrane in the lower part. The interosseous membrane is carefully incised along the entire length of the required bone. The supramalleolar perforator can be seen at this point arising from the peroneal vessels through the interosseous membrane. We now start the posterior incision of the skin flap. Care must be taken not to injure the short saphenous vein and the sural nerve. The incision is deepened through the deep fascia until the soleus muscle is seen. The flap is then retracted anteriorly and a plane is developed deep to the soleus muscle. This is a relatively avascular plane. Small branches from the peroneal vessels entering into the soleus muscle are clipped. Note that these branches often arise at the very same location from where the skin perforators originate. The FHL muscle is seen deep to the soleus muscle. As we go proximally, we identify a soleal musculocutaneous perforator in the proximal part of the flap. Note that this perforator was not visible from the anterior side of flap harvest. If we need a second skin paddle, it can also be harvested on this perforator. This perforator can be dissected through the soleus muscle in a standard musculocutaneous perforator flap harvest fashion. Branches from the perforator to the muscle need to be ligated or clipped. In this case, since we already have a good supramalleolar flap, we do not need to harvest skin island based on this perforator. This short dissection is just to demonstrate how the perforator dissection proceeds. When we retract the soleus muscle, we can see where the perforator is joining the peroneal vessels, and it would have been a very long, tedious intramuscular dissection to harvest this perforator. Now we score the fascia which overlies the flexor hallucis longus muscle. This helps in separating the muscle later on. The distal osteotomy is then done. Care must be taken not to injure the peroneal vessels or the supramalleolar perforator at this point. After this, the proximal osteotomy is done. Once the osteotomies are done, the supramalleolar flap is passed deep to the peroneal longus muscle. The distal runoff of the peroneal vessels can then be clipped. The artery and the vein must be clipped separately. Once the peroneal vessels have been clipped, we start dividing the tibialis posterior muscle. This is a chevron-shaped bipinnate muscle, and it is best to divide the muscle in the midline. This is a relatively avascular plane in which to divide the muscle. However, we must be careful of bigger vessels which may need to be clipped. Once the entire tibialis posterior muscle has been divided, the last remaining attachment of the fibula bone is the FHL muscle. And the FHL muscle is then divided just away from the peroneal vessels. Larger branches which are entering into the muscle may need to be clipped. In this patient, the FHL muscle is relatively long and originating quite high up on the fibula, and this part of the FHL muscle is divided from the posterior approach. Once the FHL muscle has been divided, we can see the posterior tibial vessels, the tibial nerve, and the peroneal vessels as they originate from the common tibioperoneal trunk. These are dissected for a short distance until the origin of the peroneal vessels. This completes the flap harvest. We shall now see a few case examples to demonstrate the utility of a chimeric double paddle fibula flap. The first case example is a full thickness central arch defect where the lateral supramalleolar component was used for the external skin defect. The second example is a lateral full thickness defect where two skin islands supplied by septocutaneous perforators were used for internal as well as external defects. The last example is also a full thickness lateral oromandibular defect where the skin island supplied by soleal musculocutaneous perforator was used for the external defect. Thank you.